Thanks everybody for being here. I'm Suzanne Mazer. I'm the Director of Continuing Medical Education here at Seattle Children's. And without any further announcements, I will introduce our esteemed speaker of the day, brought to us thanks to Indy Trehan, who is one of my colleagues in emergency medicine and also infectious disease here at Seattle Children's. So this is one of his friends from his former life at Washington University. And this is Dr. Stephanie Fritz, who's an associate professor of pediatrics in the Division of Infectious Diseases at WashU School of Medicine in St. Louis, Missouri. Dr. Fritz leads a multidisciplinary translational research team focusing on community-associated MRSA. Dr. Fritz is a fellow of the American Academy of Pediatrics, Infectious Disease Society of America, and Pediatric Infectious Diseases Society. Her research accomplishments have been recognized with the PIDS Young Investigator Award and the WashU Medical Center Alumni Association Resident Fellow Alumni Achievement Award. Dr. Fritz is also the Pediatric ID Fellowship Co-Director at the Washington University School of Medicine and St. Louis Children's Hospital, and she is passionate about training the next generation of physician scientists. So we're so excited to have you here, Dr. Fritz. Welcome.
Well, thank you so much, Suzanne, and to Indy for the invitation. I'm very excited to share our work with you guys today. I have no disclosures and just want to clarify that consent was provided by all individuals portrayed in this presentation. So some Grand Rounds presentations begin with a patient with a very rare disease. And the case that I would like to present today represents patients who are seen multiple times each day in many children's hospital emergency departments across the country. So this is a case of RF, and she is a 3-year-old previously healthy female who presented to our St. Louis Children's Emergency Department with a 2 by 2 centimeter cutaneous abscess on her anterior thigh. She had no systemic symptoms. She underwent sedation and an incision and drainage procedure and was sent home with a 10-day course of trimethoprim sulfamethoxazole. And her drainage fluid was sent for culture, and it grew methicillin-resistant Staph aureus. So again, pretty standard and basic for what we see in the emergency department. But as we follow this young lady over the next year or so, over the next several months, she unfortunately had 5 additional episodes of cutaneous abscess on her lower extremities and buttocks. 9 months after her initial presentation, she was hospitalized with systemic symptoms and a large cutaneous abscess with extensive cellulitis over her right buttock, for which she required IV antibiotics. During this time, her 7-month-old brother was hospitalized with a retropharyngeal abscess. They were actually hospitalized at the same time, and the drainage from that grew MRSA. And over the course of these 9 months, the mother also experienced 2 abscess episodes. So definitely a burden. And so by way of introduction, as many of you know, Staphylococcus aureus is a commensal bacterium that commonly lives on the skin or in the nose of healthy people. About 1/3 of the population are colonized with Staph aureus. And Staph aureus is also a successful pathogen, as we'll see. So our outline today, I'd like to give you a historical perspective of Staphylococcus aureus. Then we will talk about the emergence and epidemiology of community-associated methicillin-resistant Staph aureus. We'll talk about treatment of these infections as well as prevention of recurrent disease, and then end talking about household transmission dynamics of MRSA. So this is a line of the evolution of Staph aureus, and penicillin was introduced for widespread use in 1946. And at that time, many infectious disease physicians were told that they would soon be obsolete with this new magic bullet. However, only 1 year later, the organism had evolved such that many strains had become resistant to penicillin. Outbreaks caused by these penicillin-resistant Staph aureus strains caused such alarm that the American Medical Association convened an emergency meeting entitled Conference on Staphylococcal Infections in the Hospital and Community. The main focus of this emergency conference was outbreaks of Staph aureus infections originating in newborn nurseries. During this epidemic, the infants were discharged home, typically on day of life 4 or 5, and were appearing healthy. However, several days later, many of them returned to the hospital with Staph aureus infections, including skin infections, pneumonia, osteomyelitis, and sepsis. Unfortunately, the infection was frequently transmitted to the infant's mother, causing breast abscesses and sometimes sepsis, and it often spread to other family members. These infections were caused by a hypervirulent antibiotic-resistant Staph aureus strain called phage type 8081. The men at the forefront of the investigation of phage type 8081 were Doctors Heinz Eichenwald and Henry Scheinfeld at Cornell University. Eichenwald and Scheinfeld discovered that Staph 8081 was floating in the air of the newborn nurseries, and the source of this was infants without symptomatic infections who were colonized with this strain type. Eichenwald and Scheinfeld asserted that antiseptic or antimicrobial agents were not consistently successful in preventing or terminating epidemics, and they were associated with colonization with abnormal flora, which may have undesirable consequences. Thus, they believed that the key to ending the 8081 epidemic was to prevent colonization with a more biologic approach. And to do this, they decided that they needed an even better colonizer. And it's just really fun and interesting to read this historic literature because it just really mirrors exactly what we face today. So in conducting active surveillance, these investigators discovered a Staph aureus strain they called 502A. And this strain was susceptible to penicillin. It was present in babies not colonized with strain type 8081. And when they followed these babies after discharge, they found that very few of them returned with symptomatic infection. They then performed an experiment in which they moved babies who were colonized with Staph aureus 502A into nursery rooms with babies who were shedding strain type 8081. And they found that the infants who were colonized with strain type 502A did not become colonized with strain type 8081. Thus, they began deliberately inoculating newborn infants within the first hour of life with strain type 502A in the anterior nares and the umbilical stump, and this practice quickly swept the country. Unfortunately, this procedure was not completely innocuous. At some centers, up to 1/3 of the infants developed skin pustules, like those shown here. Others developed conjunctivitis and recurrent skin abscesses. And unfortunately, in Texas, one infant developed septicemia and death. And so due to those adverse outcomes, bacterial interference fell out of practice. Then around that same time in 1959, methicillin, a new wonder drug, was introduced, and it was marketed as Salbenin. Methicillin is a synthetic penicillin derivative, and upon its introduction was advertised as effective against all resistant staphylococci, with resistance unlikely to develop. However, as you all know, only 2 years later, the germ had evolved such that some strains had become resistant to methicillin. Then over the next 20 years, MRSA was primarily a nosocomial infection, so affecting the elderly, individuals in nursing homes, those who had undergone surgery or were on dialysis or were exposed to prolonged courses of antibiotics. Then in 1981, there was an MRSA outbreak noted in IV drug users in Detroit, and these individuals did not have those traditional healthcare associated MRSA risk factors. And in 1993, there was an outbreak reported of MRSA infections in previously healthy women who did not have those the traditional healthcare risk factors and were also not IV drug users. So this piqued everyone's interest, but what really sounded the alarm bells was in the late 1990s, there were 4 deaths due to new hypervirulent strains of MRSA in totally normal, healthy children who did not have those traditional risk factors. These new strains were designated community-associated MRSA, reflecting the fact that they cause disease in individuals without the traditional healthcare-associated risk factors. And of course, now these strains of community-associated MRSA are widely disseminated, and MRSA has received a threat level of serious by the CDC in their pathogen threat report, which means that it requires prompt and sustained action to ensure that the problem does not grow. So next, let's talk a little bit more about the emergence of community-associated MRSA. So MRSA, community-associated MRSA, causes a spectrum of entities. So some individuals can be colonized with the organism, which means that it lives in their nose or on their skin, and they just can live harmoniously together. And about 2 to 10% of the population are colonized with MRSA. MRSA colonization, though, does pose risk for subsequent infection, including skin and soft tissue infection, which is the most common entity caused by community-associated MRSA. It accounts for 8.4 million ambulatory visits and 800,000 hospitalizations in the United States every year, and many patients will experience a recurrent infection. And then unfortunately, some of our patients develop invasive life-threatening infections such as bacteremia, necrotizing pneumonia, and musculoskeletal infections. And these infections account for nearly 20,000 deaths in the US each year. And these infections are really expensive, accounting for $16 billion in healthcare and societal costs annually in the US. So from the late 1990s to the early 2000s, there was a dramatic increase in the rates of Staph aureus infections across the country, which was driven by this new community-associated MRSA demonstrated here in purple. While you can see here in green, the healthcare-associated MRSA infection rate stayed rather consistent. Community-associated MRSA strains are distinct both clinically and genetically from healthcare-associated strains. So as we talked about, the healthcare-associated strains most commonly affect individuals with healthcare contact, whereas the community-associated strains affect individuals who are healthy outpatients. The healthcare-associated strains are frequently resistant to multiple antibiotics, whereas the community-associated strains are mostly susceptible to non-beta-lactam antibiotics. Pulse field gel electrophoresis is kind of the parlance for our strain typing. And so the most common healthcare associated strain type is USA 100, whereas USA 300 is the most common community associated strain. And then the community associated strains possess enhanced virulence properties. So given the enhanced virulence of the USA 300 strains, a significant number of children with these infections require hospitalization, which has led to the introduction of these strains into healthcare settings, creating a new set of challenges for infection prevention practitioners. And in particular, the cohabitation of virulent USA 300 strains with those multi-drug resistant USA 100 strains has led to the acquisition of additional resistance determinants by these virulent USA 300 strains. And in many healthcare settings, USA 300 is now the most prevalent strain type. In recent years, however, we have started to see some shifting susceptibility. And so this is a retrospective surveillance study of antibiotic susceptibility reports from infections in pediatric patients in the military health system. And this spans superficial and invasive infections and comprised almost 42,000 annual first positive Staph aureus isolates. And so you can see here in 2005, 2007, we saw a decline in oxacillin susceptibility, or the inverse of that would be methicillin resistance. But then in more recent years, we've started to see more methicillin susceptible strains causing these infections. So, so the pendulum may be swinging back, but what's really interesting is that when we look at the genetic backbone of these MSSA strains, many of them have that hypervirulent USA 300 genotype. Okay, next, I'd just like to talk briefly about the treatment of community-associated MRSA infections. So 10 years ago now, our Infectious Diseases Society of America published clinical practice guidelines for MRSA prevention and treatment in adults and children. And for cutaneous abscess treatment, at that time, they stated that incision and drainage is the primary treatment. IND alone is probably sufficient for simple abscesses, but additional data are needed to further define the role of antibiotics in this setting. Since that time, since the publication of those guidelines, there have been two very large randomized trials that have definitively provided data regarding the role of systemic antibiotics in SSTI management. And I'll just share one of them with you today, but they have similar findings. So this was a 6-center study that enrolled patients of all ages with limited abscesses, so those that were 5 centimeters or less. And these participants were randomized to receive either clindamycin, placebo, or trimethoprim sulfamethoxazole, and the study drug was administered for 10 days. What they found is that in the individuals who received active antibiotics, so the clindamycin or trimethoprim sulfa, at the test of cure visit, which occurred a week to 10 days after the completion of antibiotics, those individuals who received clinda or trimethoprim sulfa were more likely to achieve clinical cure compared to those who had received placebo. And as I mentioned, there's another trial that shows similar results. So I mentioned that recurrent skin infections are especially burdensome and are a huge source of frustration for both patients and healthcare providers. And this burden has long been recognized, even in this 1940 textbook, that once an organism gains a foothold, they may be very difficult to eradicate. Sometimes boil after boil appears, and these lesions may continue to develop in crops for months. And indeed, more than 50% of patients with skin and soft tissue infections will develop a recurrent infection over 1 year. When we look at the molecular epidemiology, 90% of the recurrent skin infections are caused by a strain type identical to that prior infection. And so one important aspect, I think, of the randomized clinical trials looking at antibiotic treatment of skin and soft tissue infections is that for the patients who received clindamycin, they actually had a significantly lower incidence of recurrent infection at the 1-month follow-up visit. So not only did active antibiotic result in a higher likelihood of clinical cure, but also for those who received clindamycin, they were less likely to have a recurrent infection. So let's talk a little bit more about other strategies regarding prevention of recurrent disease. So given that there is not an effective Staph aureus vaccine, how do we approach this huge problem of recurrent infection? Well, the current Infectious Diseases Society of America guidelines address recurrent SSTI and are based on expert opinion and recommend first emphasizing personal hygiene and appropriate wound care. So in addition to keeping hands clean and regular bathing, they encourage avoiding sharing personal hygiene items and using barriers between bare skin and surfaces touched by multiple people, such as exercise equipment. So I think these are tenets that have been promoted for another infectious disease over the last year quite a bit. But in the staph world, we've been promoting them for a long time. So given that Staph aureus colonization is a risk factor for subsequent infection, decolonization is another approach to prevention. We know that multiple sites of Staph aureus colonization are related to higher rates of recurrent infection. And so the Infectious Diseases of Society says that decolonization, which is the use of antimicrobial or antiseptic agents to suppress or eliminate Staph aureus carriage, may be considered in selective cases to prevent recurrent SSTI. And those are especially, we especially consider this in patients who have recurrent skin infections or in which there's active transmission between individuals, such as in households. Traditionally, these measures have been used in hospital settings to prevent nosocomial MRSA infections. And then with the emergence of community-associated MRSA and the resulting epidemic of skin infections, these measures have been extrapolated to outpatients. And so the approaches that are commonly used include topical antibiotics, such as mupirocin applied to the anterior nares, as well as antimicrobial baths, for example, soaking in dilute bleach water. There have been several decolonization trials conducted in outpatient settings, and I'd like to share with you one that addresses a common situation, the clustering of Staph aureus skin infections in households. This was a trial that we conducted that focused our intervention on the household unit and specifically looked at a household versus individual approach to decolonizing children with community-associated Staph aureus. So we enrolled 183 pediatric index patients who had a community-associated Staph aureus skin infection, along with concomitant colonization with Staph aureus at one of 3 body sites, the nose, axilla, or inguinal fold. We also collected colonization cultures from the household contacts of these index patients. And of our 609 household contacts, we found that 34% were colonized with methicillin susceptible Staph aureus, which is what we would expect from historic data. But we were really surprised to find that 21% were colonized with MRSA, especially given the national prevalence of 2 to 10%. So we found that individuals who live with children with Staph aureus skin infections were highly colonized with MRSA. So these individuals then were randomized to a decolonization protocol that was a 5-day protocol in which mupirocin was applied to the anterior nares twice daily. And we asked them to use Hibiclens as their body wash for those 5 days. Individuals were, or households were randomized to index decolonization, in which only the individual, the index patient who had presented with the skin and soft tissue infection, performed the decolonization protocol. Compared to our household decolonization approach, in which we asked all individuals in the household to perform the 5-day protocol. And participants were then followed for 12 months to monitor their development of recurrent infections. So this is the percent of index cases who reported development of a skin infection during the longitudinal study period. And just to orient you, the bright blue bars represent those children randomized to the index decolonization arm, and the light blue bars are the children in the household decolonization arm. And so as you can see, the incidence of recurrent skin and soft tissue infection was significantly lower in the children who were randomized to the household decolonization arm. One thing I do want to point out, though, is that even in those children in the household decolonization arm, over 12 months, 50% of them still developed a recurrent infection. So then when we looked at the household context, we also saw benefit of household decolonization in reducing the incidence of skin infection. So let's then delve more deeply into households and household transmission dynamics. So we learned in that previous study that household contacts of children with MRSA infections have a high prevalence of colonization and infection. And so we posited that a household reservoir of MRSA might perpetuate colonization and disease in household members. Studies have shown that MRSA can survive on some surfaces for months. This has especially been studied in healthcare settings. And then we have also seen Staph aureus recovered from companion animals. And this has mostly been studied in households of patients with recurrent infections, specifically like diabetic foot ulcers and chronic wounds. The traditional dogma has been that humans are the source of Staph aureus for pets, and that was evidenced by studies that show that pets often clear their colonization without antimicrobial treatment. However, the directionality of transmission was really undefined between pets and people. And to me, this was a really important question. As an animal lover, I would hear these heartbreaking stories of patients, primary care providers suggesting that they get rid of their pet because they have recurrent infections. So that was something that I really wanted to get to the bottom of. So again, we demonstrated that a household decolonization approach reduced skin infection incidence, but it didn't completely eliminate the problem. And so to really best target our therapies, we knew that we needed to take a step back to understand how staph was getting into the household, and once it was there, how it was being spread, or the household transmission dynamics. Traditionally, we have always thought of Staph aureus to be spread through close person-to-person contact. And so we wanted to investigate close person-to-person contact, but also sharing of personal hygiene items. Were there household environmental surfaces that were serving as reservoirs for household transmission? And then again, really getting to this question of whether pets play a role in household transmission dynamics. And to date, there had been a few studies that looked at MRSA in households, but they hadn't truly defined the the transmission dynamics. And so many of them had looked at a single time point or a limited time frame. They hadn't really considered the household environment or hadn't considered companion animals, and they had utilized low resolution or had not done strain typing. So we considered all of that in our design of the home study, which stands for Household Observation of MRSA in the Environment. And I just want to acknowledge this is our amazing team that did all of the heavy lifting and all of the visits and sampling for this study. So they're just a really terrific group. So the home study participants were randomized between 2012, or I'm sorry, they were enrolled between 2012 and 2015. We enrolled 150 index patients. So these were patients who had a confirmed, active or recent community-associated MRSA skin and soft tissue infection and their household contacts. These children were recruited from our 2 area children's hospitals, as well as community pediatric practices affiliated with a practice-based research network. So once we had recruited these patients and they agreed to be in our crazy study, our team went to their house to conduct an enrollment visit. And at that time, we collected swabs of the humans at 3 body sites, the nose, axilla, and inguinal fold. We cultured 21 of their household environmental surfaces, and then we also cultured their pet dogs and cats in their nose and their dorsal fur. And all of that was to look for MRSA colonization. We also conducted very lengthy interviews. We had a very extensive survey, really trying to get at factors that may be associated with MRSA infection and transmission. So we asked about household characteristics and their cleaning practices. For each individual in the household, we asked about their personal health history, their hygiene practices, including do they bathe or shower, what kind of soap do they use, how often do they launder different clothing items. And then we asked about their activities. So we asked where they went to which hair salon they went to. Do they go to a nail salon? Do they work out at a gym? And then we asked about pet characteristics, including the pet health, who was the primary caregiver for the pet, etc. And then we conducted follow-up visits at 3, 6, 9, and 12 months. Again, we went back to the participants' homes. We repeated all of the serial human, environmental, and pet swabbing. And this was a much shorter survey where we just asked about the occurrence of MRSA infections. And so this is just a sampling of the communities we visited and our representative neighborhoods across metropolitan St. Louis. So from all of those swabs that we collected at 5 visits for 150 families, we performed culture-based methods to detect Staph aureus, and greater than about 5,000 isolates were recovered and all underwent strain typing with a method called repetitive sequence-based PCR. So the repetitive sequence-based PCR, or RET-PCR, produced strain types, which just to define this for you for later on, these strain types were unique to each household and were a combination of the RET-PCR designation and the methicillin resistance profile. So you can see here, this is an output from RET-PCR. This is like a virtual gel. And so we have 2 different strain types here. One that was recovered from the index patient's infection in their inguinal fold, and then one that was recovered from the nose of our index patient, the father, and the sibling. Then all of the strain typing data and the extensive epidemiologic data were handed off to our graduate student, Ryan, who did a lot of very sophisticated statistical analyses. And the one that I will present most today were his longitudinal multivariable generalized mixed effects logistic regression models. And what's important about these models is that they account for longitudinal samplings among multiple members within households. So this is our study population. Of our 150 index cases, the median age was 3 years. We had an equal distribution of boys and girls. our racial distribution is representative of metropolitan St. Louis. We had a fairly educated population, with 50% of our population being college graduates or higher. The number of individuals per household was 4, but we had one household with 13 individuals. About a third of our participants lived in homes that were rented. And then about 2/3 of our index patients had experienced a skin infection in the year prior to the infection that prompted enrollment into the study. And about a quarter of our household contacts had experienced a prior SSTI. So we saw that about a quarter of our index patients and household contacts were colonized with MRSA at that baseline sampling. You might be a little bit surprised that the index patient colonization wasn't higher, but many of these individuals had recently received systemic antibiotics, which we know eradicates colonization. So I think that's why this was not higher. And then interestingly, we found that the strain that was recovered from the index patient's infection, so we call that their infection strain, was commonly the most frequent strain that we recovered from the household members. So that for each household, that infection strain seemed to be the predominant strain for human colonization. And then of our 150 households, about 2/3 had at least one environmental surface colonized with Staph aureus at baseline. And almost 50%, almost half of them actually had at least one surface that was colonized with methicillin-resistant staph. The median number of surfaces contaminated in each household was 3, but we had one household where 18 of their environmental surfaces were contaminated with Staph aureus. And again, similar to the human colonization, that enrollment infecting strain was the most common strain recovered from the environment in the majority of our households. So normally I love to do audience participation, but since we're virtual today, I will just share with you the most frequent sites of household environmental contamination. And so the most prevalent sites of MRSA are represented here by the purple bars, and include the index case bed linens, so surfaces that come into close contact with the patient, as well as the TV remote control and the computer keyboard and mouse. So items that are shared by many household members and likely are not cleaned very often. And so I'm just going to share a few definitions to set the stage for the rest of the talk. And so strain acquisitions were defined as a strain type that is found colonizing an individual surface, an environmental surface, or a pet who was not colonized with the given strain at the prior sampling. So just like you would expect, acquisition of a new strain to that person or surface. And over the course of 12 months, we witnessed nearly 1,300 strain acquisition events. So strain acquisitions come in 2 flavors. The first is an introduction event of a strain that was exogenous to the household. So this is where a household member, surface, or pet becomes colonized with a unique strain that was not previously observed in the household. And we saw 510 introduction events over the course of 12 months. So just to put this, I think visually, I think it helps a lot. So this is an example of one of our households. These are the people, their pets, their environmental surfaces, and then each color represents a different strain type. So, and that are defined over here in the legend. So you can see here at 3 months, we see a number of the strains that were there at the enrollment visit, but the dog, one of the dogs, had become colonized with a strain that had not been present in the household at a prior sampling. So that would be one introduction event. Then at 6 months, we see introduction of 3 new strains. This is MSSA 6, MRSA 5, and MSSA 8. And then at 9 months, we saw the introduction of 2 additional strains. So Of our 650 household members that were sampled at least twice, 38% of them experienced at least one introduction event, totaling 308 events, because one individual could experience multiple introduction events. So another way to look at this is our rate of Staph aureus introduction, which was 0.52 introductions per person sampling year. Or in other words, at least 2 individuals would need to be followed for 1 year to observe one Staph aureus introduction event. Looking at factors that were associated with introduction events, we found that introduction events occurred less frequently during warmer seasons. And although not statistically significant, more frequent hand washing did remain in our multivariable model as clinically significant in preventing introduction events. Okay, then our second type of strain acquisition is a transmission event. And this is transmission of an endogenous strain to the household. So it is where a person who was not previously colonized with a given strain becomes colonized. So they are deemed a transmission recipient with a strain that was recovered from at least one person or environmental site in the household at the previous time point. And they would be called our putative or potential transmission source. And so interestingly, we saw an equal number of transmission and introduction events in the course of the study. We also had some events that we had to deem indeterminate because they involved strains that were present in the household previously, but not at the immediately preceding sampling. So it was unclear whether these represented transmissions or reintroductions. So I'm just going to give 2 examples of strain transmissions. Here we have the brother who was colonized with strain type MSSA04 at the enrollment visit. And then at 3 months, we recovered that strain from the mom and the dad. So this would be 2 different transmission events. Then in this example, at the enrollment visit, we see MRSA01 colonizing both the dog and one of the electronic surfaces at the enrollment visit. And then at the 3-month visit, we found this strain on the index patient. And so because we can't know whether the index patient acquired this from the dog or from the electronics, we count these as 2 different transmission paths. And this is why that's important, is just to show you that of our 650 household members who were sampled at least twice, 205 were transmission recipients through 297 transmission events, because again, someone could be a transmission recipient more than once. Other household members served as potential sources in 545 transmission paths and environmental surfaces in 178 transmission paths. Then our rate of Staph aureus transmission was very similar to introduction, 0.5. So again, we would need to follow at least 2 individuals for 1 year to observe one Staph aureus transmission event. Transmissions were most common between siblings, as well as from children to their parents. But interestingly, cohabitating parents rarely transmitted their strains to each other. Our source and recipient pairs frequently shared a bedroom, independent of sharing a bed, although sharing a bed was also statistically significant. And these pairs also shared towels. So you might ask, well, what is the significance of being a transmission recipient? So you get a new strain, big deal. But we found that the transmission recipients were more likely to report a skin and soft tissue infection during that same interval. So perhaps acquisition of a new strain to you puts you at risk for developing a skin infection. Okay, then as I mentioned, the environment was also a significant source of transmission to the humans. And in 35% of the transmission events, the environmental site served as the sole source. So, so really emphasizing that the household environment can serve as a reservoir for transmission. And these are the most frequent potential transmission sources that we saw. So in a particular, or in a household where we found a particular strain in the environment at least once, for example, 63% of the time that strain was on the remote control, and that was a potential source for the human recipient. And so you can see some of the other highly transmissible or sources that were potential sources were the video game controller, the computer keyboard and mouse, the refrigerator handle and kitchen hand towel, the bathroom countertop and light switch, the soap bar, specifically a bar of soap, and the soap dish, and then the index patient's bed linens. So over the course of 12 months, we had 540 participants who completed all 5 samplings. Of those, 39% were persistently colonized, which means that they were colonized at 2 or more consecutive samplings. They were most likely to be persistently colonized in the anterior nares and to be colonized with the index infecting strain type. The individuals who were persistently colonized frequently lived in houses that had a high burden of environmental contamination, so a higher number of surfaces that were contaminated with that strain type. Interestingly, though, our patients who had applied mupirocin during that interval were less likely to have persistent colonization. Then over the course of 12 months, we saw that 53% of our index patients and 19% of our household contacts developed a skin and soft tissue infection. The individuals who developed skin and soft tissue infection were more likely to have persistent MRSA colonization. They were more likely to have a history of skin and soft tissue infection prior to study enrollment, and they were more likely to be our index patients. So then I know the exciting part for me is looking at pet colonization. And so we had 71 households with pets, and of those, about a third had a pet that was colonized with Staph aureus. And in 6 of our households, there were multiple colonized pets. So we had 100 dogs and 32 cats. And of our 100 dogs, about a quarter were colonized with Staph aureus, and the majority of those were with MRSA. Of our cats, only 13% were colonized, but again, the majority were with MRSA. We looked at a number of different factors to discern factors associated with pet colonization, and the only one that was ever statistically significant was caretaker colonization. So when a primary caretaker, which was the human who was primarily responsible for the feeding, exercising, and waste cleanup of that pet, so when that person was MRSA colonized, 50% of their pets were colonized versus just 4% of the pets whose primary caretaker was not MRSA colonized. And then looking at transmission paths, so this is really that big question, right, of directionality. And so we found that 35 pets were transmission recipients coming from humans and the household environment. And then 15 pets served as potential transmission sources across 26 transmission paths to people. And it's important to note that there were only 3 transmission paths in which the pet was the exclusive source. There was no one else, or there weren't any other environmental surfaces that were colonized with that strain type. So in my opinion, the directionality really is from the people to the pets. And then, as I mentioned, we looked at a lot of different factors, and pets associated with transmission were not more likely to share a bed with a household member, exhibit signs of poor health, or report a history of SSTI. So my long story short is people do not need to get rid of their pets. Okay, so then to kind of tie this all together, all of this household colonization, infection, transmission. So we have our individual here who is colonized, perhaps persistently, with Staph aureus or MRSA. She goes on to develop a skin and soft tissue infection. This is a risk factor. She then goes on to deposit or transmit her Staph aureus or MRSA to a variety of household environmental surfaces, which then can serve as transmission reservoirs to the other household members. So that environment, as well as direct person-to-person contact. Then some of her household members become colonized with Staph aureus, or she is now at risk for persistent colonization. Some of those individuals in the household go on to develop a skin infection, and the cycle persists. And so in our last few minutes here, I just wanted to talk about our household decolonization approach. And so in our previous trial, we had demonstrated that a household decolonization approach reduced the incidence of skin and soft tissue infection. However, decolonizing all household members poses a substantial time and financial burden on families. Widespread use may lead to antimicrobial resistance, and topical antimicrobials may disrupt the commensal microbiota. So we also know that prior skin infection increases risk for recurrent skin and soft tissue infection. And so this raised the question for us whether targeting decolonization to individuals with skin and soft tissue infection in the prior year, whether that could be as effective as decolonizing all household members to prevent skin infection and to reduce this burden. So again, we followed our families in the home study for 12 months. And at the end of that 12-month study, they were offered enrollment into the Home 2 decolonization study. And so this was an open label, non-inferiority randomized clinical trial that compared a household decolonization approach to a personalized approach. And I'll explain that on the next slide. So the randomization, the decolonization protocol here was we asked individuals to perform some enhanced hygiene measures. For 5 days, they applied mupirocin to the anterior tip of the nares, and they soaked in dilute bleach water once daily for those 5 days. Individuals were randomized to household decolonization, or at the household level. Here again, asking all household members to perform that 5-day decolonization protocol. And then in our second group, our personalized decolonization group, we targeted decolonization to those individuals who had developed a skin and soft tissue infection during the 1-year home study. Then these individuals were followed for an additional 12 months, and our primary outcome was the development of a recurrent skin infection at 15 months or 3 months following randomization. And so this is our study population. The demographic and clinical characteristics were similar between the two groups, but I just want to highlight that despite randomization, the participants in the personalized group had a higher baseline prevalence of MRSA colonization than the household group. And so here are the results. And as you can see in our univariate analysis, there was no difference in the cumulative skin infection incidence between the personalized and household approaches. And indeed, non-inferiority of the personalized approach was established with 10% of participants in each group reporting skin infection by 3 months. Then because of that difference in baseline MRSA colonization, we performed a cumulative hazard model. And you can see again that there was no difference between the two groups. In our multivariable regression model, factors associated with cumulative SSTI were MRSA baseline at colonization and SSTI in the past year. And once again, treatment approach was not significant. Another outcome of interest was protocol adherence. And although not statistically significant, we found that the participants in the personalized group had a higher rate of adherence to the protocol than those in the household group, suggesting that there is less burden. So in conclusion, the epidemiology of methicillin resistance in Staph aureus infections is shifting. We had a huge surge of community-associated MRSA, and now we're starting to see the pendulum swing back to susceptible staph. Recurrent skin infections pose a significant burden, and SSTI management that includes systemic antibiotics in conjunction with incision and drainage results in fewer recurrent infections. We found in our original study that a household approach to decolonization was more effective than decolonization of the index patient alone, but we found that targeting decolonization to just the individuals with a history of skin infection is just as good as the household approach and potentially has less burden. And then the household environment is a reservoir for Staph aureus transmission. And so we really need to think about targeting not only individuals with our prevention strategies, but also household surfaces. And we have an ongoing trial right now looking at household surface decontamination. So I would like to acknowledge my amazing research team, as well as my collaborators, and especially our patients and families who have led us into their homes and provide a snapshot into their lives. And then, of course, my funding sources. So with that, I'd like to thank you all for your attention, and I would be happy to take any questions.
Awesome. Thank you so much. Hope you guys can hear me. The Pets of America also thank you, Dr. Fritz. I think that's really, really important study. And I do have a question about this year of COVID, and maybe you covered it and I missed it, but have people's behaviors with, in terms of like surface cleaning and being really, really good about hand hygiene changed the rates of MRSA that you've seen?
So, Suzanne, that's a great question. Definitely, the incidence of children who are presenting with skin infections has been way down over the last year. Some of that may be reluctance to come to the hospital, but like I said, a lot of these these methods that we've been recommending for a long time to prevent staph are now being widely implemented. And so we actually have data before and after the pandemic, and we're really excited to look at that and to look at people's hygiene and their environmental cleaning and things like that. So definitely a great question.
Yeah, interesting side effect of the pandemic. And then can you comment on the bar of soap incidence? And does that change your recommendations about soap bars versus liquid soaps in homes? That question's from Susan Marco.
Yes. So I don't have right in front of me the incidents, but we also have done other studies where we were just in the lab and we inoculated different types of soap with staph. But we did, in this study, we did find it on the soap bars and in the soap dishes. And so we do recommend to all of our families that they use liquid soap instead of bar soap. We also discourage them from applying it to a loofah or a sponge. And so we ask them just to use a fresh washcloth every time they take a shower or bath.
That's great to know. And from Glenn Tamura, thanks for a fantastic talk. Any thoughts on chlorhexidine versus bleach?
Yes. So, the two have been widely studied, and we actually did a study where we compared the two. We found that the individuals who did bleach baths actually had a longer or a more sustained decolonization, but the incidence of skin infection did not differ between the two. I will say that in the home 2 study, we used bleach because it is less expensive and we wanted it to be more accessible for people. We wanted to use something that was more accessible, but it is super inconvenient for a household, especially of 5 or 13 individuals, to all take dilute bleach water baths. But another interesting thing about bleach baths versus chlorhexidine is that the dermatologists have been prescribing bleach baths for patients with eczema for a really long time. It's been demonstrated to reduce the burden of Staph aureus, and it seems to be less irritating than chlorhexidine. So for patients who have sensitive skin, the dilute bleach water baths might be better, but I recommend them equally to our patients.
Thank you. And from Indy Trehan, do you see any evidence that introduction of new strains leads to less severe infections? In other words, do people develop some immunity or partial immunity that is then somewhat protective against abscesses and other clinically significant infections from a new strain?
Indy, that's a great question. And not specific to strain type, there has been research that shows that patients who have invasive infections seem to develop immunity and don't have recurrent infections versus these patients who have skin and soft tissue infections that seem to keep having recurrence, and there doesn't seem to be any type of immunity. Regarding the strain types, I thought it was interesting. We didn't judge the severity. We didn't measure the abscesses and we don't have that level of detail. But I did think it was interesting that the individuals who acquired a new strain were more likely to develop an infection. And so to me, that makes me wonder, do we all have a harmonious strain that we live with? And then once we acquire that new strain, that then puts us at risk for infection development.
All right, and then some comments for you. Gold standard grand rounds, information important to clinicians, researchers, and families. Thank you, Dr. Fritz. And that's from Jerry Zimmerman. And then from Susan Marshall, also fantastic grand rounds. And I agree. So thank you so much for being here. I'll be quiet for another 30 seconds to see if anybody else is typing, and then we can let everyone go on, and we'll see you all next week. Oh, here's one more. Have you studied any of the strains to look at toxin secretion levels?
We have not. We have a freezer full of isolates, actually 3 freezers full of isolates. And so we would be happy to collaborate with anyone who is interested in doing that work.
Well, Dr. Barub, if you want, we can put you in touch with Dr. Fritz. So thank you for that question. All right, I don't see any more questions, so I will let everybody go for the day, and we'll see you all next week. Dr. Fritz, thank you so much. It was great meeting you virtually. Sometime maybe we'll have to have you meet us in person once we are able to travel again, but we really appreciate your time and your expertise, and this is a perfect grand rounds for us, so thank you so much for being here.
Well, thank you so much for having me. I really enjoyed it.